Welcome and thank you for coming. This is our webinar series from the Yver Foundation. It's called Sight and Sound Bites. This bi-weekly webinar series, we highlight the research at the University of Pittsburgh School of Medicine. Today's topic is, I'm looking forward to, it's a very interesting topic. It's the management of facial trauma. Obviously, this is something that our Department of Otolaryngology and Head and Neck Surgery deals a lot with, and they are experts at, and you're going to enjoy today's presentation and our speaker today. I'm Lawton Snyder. I'm the CEO of the Yver Foundation. The Yver Foundation supports research to advance care for vision, hearing, voice, cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology head and neck surgery at the University of Pittsburgh. The funds we provide from the Yver Foundation to support research are only made possible because of philanthropic support. So we appreciate everybody who has found a way to help us philanthropically. You can certainly easy to find how you can do that by going to our website. Little housekeeping rules. Our chat is disabled for this webinar series, but we do use the Q&A function. So you'll see a little Q&A function, and that's where you can submit questions, which you can do at any time. And then we will get to those questions and answer those questions. If you're thinking about a specific personal question related to your own personal care, I'd refrain from putting it into the Q&A, but maybe send us an email with that question, and we'll get to that at a different time. But also feel free to use the subtitle function for closed captioning. You just need to click on that, and you'll have the closed captioning. And then you'll be added to our email list, which we want you to know for future webinars, but you can always get off of that anytime you like as well. So today's presenter is Dr. Christine Yver, who is the Division Chief of Facial Plastics and Reconstructive Surgery and the Director of UPMC Facial Nerve Center. She's an assistant professor at the Department of Otolaryngology and Head and Neck Surgery. Dr. Yver is a member of the American Medical Association, Alpha Omega Alpha Medical Honor Society, American Academy of Facial Plastics and Reconstructive Surgery, American Head and Neck Society, and the American Academy of Otolaryngology-Head and Neck Surgery. She is double board certified by the American Board of Otolaryngology and the American Board of Facial Plastics and Reconstructive Surgery. Dr. Yver aims to grow the facial nerve program with the Otolaryngology department and help teach residents and trainees about the most modern advances in the treatment of facial nerve disorders. She also hopes to expand the presence of facial plastic division as it pertains to the treatment of other facial plastic surgery conditions such as facial trauma, facial reconstruction, and cosmetic facial plastic surgery. Dr. Yver, thank you for doing today's webinar. Welcome, and we look forward to hearing your presentation.
Excellent. Thank you, Lonnie, so much for that kind introduction. And please, at any point, jump in if there's any issues with audio or the presentation of the slides, but hopefully we troubleshooted everything beforehand. I had the honor of giving one of these webinars. I think it was maybe over a year ago now, on one of my favorite topics, the treatment of facial nerve disorders. So I was really excited to be invited back to speak on a different topic that makes up a large part of my practice. And then that's the management of facial trauma. So this is a very satisfying aspect of my practice. It keeps me very busy, and it keeps me on my toes. And I think it's relevant to a lot of patients. So I'm excited to give you all a little bit of an overview on that today. I have no relevant disclosures related to today's talk. And I'll start by just summarizing the objectives for today. I just really wanted to give everyone kind of a high-level introduction to the complexities of the management of facial trauma and why this is so important for our division. So I'll start by just describing common types of facial trauma, the kind of things we take care of, because it's a very kind of heterogeneous field. And then I won't get too technical, but I do plan to review some of the pearls for the surgical management of facial trauma, so you can see what goes into these cases and the clinical decision making. And then finally, I will conclude with just an overview of current challenges and future directions in the space with a little highlight on some of the research we're doing. So I'll start with a discussion of the epidemiology of facial trauma. We see a lot of trauma at UPMC. We have two level 1 trauma centers, Presbyterian and Mercy. So we get referrals and transfers from all over the region, from Western PA to West Virginia to Eastern Ohio. These patients come from quite a distance. And out of all these traumas, we see facial injuries represent a large portion of them. Up to 15% of all traumas have some sort of a facial component. In terms of the patients affected, as you might expect, males do tend to be disproportionately affected, typically accounting for between 70 to 80% of all cases. Peak incidence generally occurs in younger adults between the ages of 20 and 40. However, with certain mechanisms, such as like falls, we see those more commonly in the elderly and in the young children. So it is a pretty heterogeneous patient population. So I guess one question is, what falls under the umbrella of facial trauma? Generally, when people are talking about facial trauma, they're talking about fractures of the bony facial skeleton. However, facial trauma also encompasses orbital trauma, and we often co-manage those with our ophthalmology colleagues, dental trauma, soft tissue trauma. You'll hear me refer to mandible fractures. So these are fractures of the jawbone. You can have fractures of the bones of the midface. You can have nasal trauma. You can have orbital trauma. So trauma or fractures of the bony orbit or of the eyeball itself. Dental trauma, penetrating soft tissue injury, and then unfortunately sometimes ballistic trauma. So kind of high velocity, a lot of soft tissue and bony destruction from those types of etiologies. All right. So I'll do a little bit of a deep dive into some of the big categories of facial trauma that we see most frequently. And I figured I would start with a discussion of mandible fractures, because these are one of the most common types of facial injury that we see. So the most common etiologies for mandible fractures tend to be things like sports, motor vehicle accidents, assault, unfortunately, and then also falls are pretty common, especially in the winter. These patients tend to have several kind of like pathognomonic findings when they first present that kind of raise your suspicion that they might have a mandible fracture. So if a patient like walks into the ED, they have bruising over their jawbone, they have fractured teeth. Sometimes you can actually palpate, like with your finger, a bony step off of the mandible. Sometimes those segments of the mandible are actually mobile, and you can appreciate that on the exam. Sometimes these patients have numbness of their lower lip or chin, and that's because there's a nerve that runs out of a bony foramen here in the front of the mandible called the mental nerve. And so when that's involved by a fracture, that can cause numbness. Finally, malocclusion is the big one. What that means is the teeth aren't coming together properly. So patients will complain that maybe their bite is off or they're not able to bring their teeth together in the way that they're used to. And that is pretty specific for a mandible fracture. These can be quite morbid. So if untreated, these mandible fractures can lead to all sorts of problems. You can have chronic malocclusion where the bite is kind of forever affected. Some of these patients can have trismus. That means they're unable to fully open their mouth. These fractures, if they're not properly reset, can cause malunion, which means the fracture never quite heals properly, or the bone in that area gets chronically infected and starts to break down. And all of these things can lead to issues like chronic pain, chronic functional issues, and also cosmetic deformity. So generally what happens is these patients will present to the ED, either our ED or one of our referral centers. And if there's any concern, they'll get imaging, typically a CT scan. If this demonstrates a mandible fracture, they're evaluated by the on-call facial trauma team. In the otolaryngology department, we share facial trauma call with both the oral surgeons and the plastic surgeons. So if we happen to be on call, typically, one of our residents will assess the patient in the emergency room and determine the nature of the fracture and usually make a preliminary call on whether that fracture is operative or not. If it is operative, it really needs to be addressed typically within 14 days or as soon as possible. Now, one point I want to make is that mandible fractures can be kind of tricky because you can imagine you have several strong muscles called the muscles of mastication that allow you to chew and bite down and close your jaw. And these muscles subject the various segments of the mandible to these really strong tensile forces. So for this reason, if you have a fracture line, even if it's like a small fracture or it's non-displaced, the two fracture segments can kind of like grind against each other long term, like moving against each other. And that makes it impossible for the fracture to heal. So oftentimes, even a small non-displaced fracture, especially if it's up in the front of the mandible, it's usually operative because you have to immobilize everything in order to give the bone a chance to heal. That being said, there are mandible fractures that we can treat with observation, meaning no surgery, but those patients typically are instructed that they have to do a soft diet for 6 weeks. Sometimes, we don't actually have to open up the fractures, but we can treat them with a closed reduction, also called a maxillomandibular fixation or MMF. I will elaborate a little bit on this, but this is basically when we have to wire the jaw shut. Finally, the most common way we treat these fractures is with an open reduction and an internal fixation. That just means we make incisions. We actually directly access that fracture by exposing it. We put it into proper alignment, and then we put plates on it to hold it in place. Okay, so MMF, again, not to get too technical here, but this is a really important part of treating mandibular trauma. Because it's really important, regardless of how you're treating this, you want to ensure that the teeth are coming together perfectly when you let the fracture heal. And there's different ways you can wire a patient shut. The traditional way is via arch bars, which are these kind of heavy metal bars that are secured to the teeth with wire, and then you use additional wires to secure, the upper teeth to the lower teeth. They're really strong, they're reliable. You can leave them on for, up to 6 weeks. But they honestly are time consuming to apply, can take up to 45 minutes. And there you go. Patients obviously don't love them. There's other systems that we can use for this purpose. There's these IMF systems where you can put these very small screws into the gums and then wire the patient shut that way. Or you can just put isolated screws and do kind of a quick and dirty wiring shut. That's just traditional IMF screws. And that's fine if you're only going to wire them shut in the operating room to put the plates on. But you wouldn't want to leave someone like that long term because it's not quite stable enough. So just to give you a little bit of an overview for how we might manage a case like this. So if you are going to take someone to the operating room and actually plate a mandible fracture, do an ORIF, first of all, you have to put them to sleep. As you can imagine, for most patients, when they have surgery, they need a breathing tube, and usually that breathing tube is placed through the mouth. But obviously, that's not going to work in a case like this if you have to wire the jaw shut for the surgery. So these patients often get a nasal intubation. Once they're asleep, we proceed by exposing and mobilizing all these fractures. And so you might ask, how do you actually access these fractures? I'd say the most common way we do this is through transoral incisions. So we make incisions inside the mouth, and that allows us to get onto the bone, find the fracture line, and mobilize it. For some fractures, especially large comminuted fractures where there's a bunch of different pieces, also fractures further back in the mandible, we might make a transcervical incision. So that's an external incision where we then dissect down onto the jawbone. But this can be tricky because you have to be really careful that you're not injuring any branches of the facial nerve in that area. There's also a lot of large arteries and veins that you have to mobilize and work around. Anyways, you get all the fractures exposed and mobilized, and then you have to place the patient in MMF. And this is really crucial because you got to establish their normal bite, their normal occlusion before you put plates on, because the last thing you want to do is put plates on, and then you find that you've kind of like plated them into a poor occlusion, and then that's a tough thing to fix. So you place them in MMF, make sure you have a good occlusion, and then you start putting the plates on. And I could get real technical here, but the basic idea is you usually start up front, work your way backwards, put appropriate plates on all the fractures. And then when you're finished with that, you want to get them out of occlusion, so cut the wires and make sure they're able to kind of reestablish their bite on their own. And then if everything looks good, you're happy, you close up all the incisions and you wake them up. And that's basically how it goes. I maybe made it a little oversimplified. I wanted to give you all a sense, though, that there's a lot of nuance to how we manage these fractures and how we put the plates on. So, for example, there is a organization called the AO that provides guidance for a lot of bony trauma, and they work with orthopedic surgeons and neurosurgeons, and they also have a section on craniofacial trauma. And so, what you can actually do is you can go online on their free resource online. you can look up any type of fracture or fracture pattern and get suggestions on how would be an appropriate way to manage that fracture. And unfortunately, you can get, various different, there's various different ways that you can manage any given fracture. So a lot of it is nuanced and up to the surgeon's discretion. So if I were to search like a simple symphyseal fracture, like I did here, there's 4 different potential ways that I could manage that fracture. And so every surgeon has their own preference, and they can take it into account, aspects of the patient's, social situation and the patient's preference. But there is a lot of judgment that goes into how to manage each individual fracture. I'll give you maybe a little taste of what I mean by that by presenting a case example. So this is the patient that came to me when I was on facial trauma call. This was a 42-year-old male. He presented with facial trauma, actually, unfortunately, after a domestic violence situation. And I don't think he was expected to get hit back. And so when he presented, he had 2 mandible fractures. He had one up front. This is a parasymphyseal fracture that you can see in the photo on the left, going right through the front of the jaw. And then further back here, you can probably appreciate this very posterior aspect of the mandible called the condyle. And so he had a fracture here through the neck of the condyle. And that can lead to kind of like height discrepancy when you bite down, where you have an open bite on one side because you have loss of height of the mandible on the other side. So my point here is you do have to take into account patient-specific factors when you're coming up with a treatment plan. So generally, when I see 2 fractures like this, the way I might manage something like this is I might plate the anterior fracture, the symphyseal fracture. But because that condylar fracture is technically very challenging to plate, I might actually treat that conservatively by leaving that patient in MMF just for 2 weeks after, and then graduating him to elastics and not even putting a plate on that. But here's the problem with this patient. He was brought in by police, and he was getting discharged. He was going to be incarcerated after he was discharged from the hospital. You really can't send someone to jail, wired shut. So in this case, we had to kind of personalize his treatment, and I did have to go in there and put a plate on that condylar fracture. And so that involves making a separate incision, actually kind of in front of the ear. And you have to dissect through this kind of really um, anatomically complex area where you have these big branches of the facial nerve riding right over that area. And so you have to kind of use a nerve stimulator to identify them, work very carefully around them, get a plate in there. You don't have a lot of access, but you have to reduce it, plate it, and then that mitigates the need for MMF postoperatively. And so we did that successfully. He woke up with good facial function, perfect occlusion. Everything went really well. He was kind of discharged as we were told. And unfortunately, I never got to see him again, which is fortunately very common in this patient population. But from my standpoint, I kind of assume no news is good news, or else they would know where to find me. Great. So I'll shift gears a little bit. I'll do an overview of midface fractures, which is kind of a whole different ballgame. The midface here is, fortunately, it's not subject to the same muscles of mastication as the mandible is. And also the occlusion is less of an issue. But it is an extremely important region cosmetically. So even minor fractures can lead to long-term changes, both in appearance and also like contour deformities. So we do take this area very seriously. They tend to follow these certain patterns of injury. So a lot of these injury complexes have specific terminology. For example, you can have a zygomatical complex fracture, you can have a zygomatic arch fracture, you can have a nasal-orbitoethmoid fracture, and then also Lafort fractures, which is a larger fracture complex I'll elaborate on. Typically, these are either treated non-operatively, or if there is a significant displacement, we'll do an ORIF and put a plate on the displaced segment. Typically, if there's a significant displacement on imaging or a perceptible cosmetic deformity. Now, the tricky part of midface fractures is figuring out how to actually access the fracture. Because as I mentioned, this is a very cosmetic area, right? It's the middle of your face. So you don't want to just make an incision wherever, cut right down on the fracture and leave an unsightly scar. So we work with these kind of defined surgical approaches to the midface, where we take advantage of locations where you can put a very cosmetic incision, which will ultimately turn into a scar that's imperceptible. So for fractures lower down on the midface, we might make the incisions actually in the mouth, in the upper lip. So there's nothing external. We can make incisions, an upper blepharoplasty incision, which is an incision in the crow's feet, to access fractures of the lateral orbital rim. There's kind of advanced approaches like coronal approach, lens incision, midface degloving. We could do transconjunctival incision, which is actually an incision on the inside of the lower eyelid. So again, you're avoiding an external incision. And so a lot of facial trauma is actually mastering these incisions and approaches. Let me give you an example of a midface fracture. This was a young man who sustained blunt trauma to the left malar region 3 days ago while he was playing rugby. And so when he presented to me, he noted his cheek was numb, but most notably on his exam to me was the flattening of the left malar eminence, which you can actually appreciate best on this 3/4 view. You can see that he has this loss of projection of the midface right there. And sure enough, this is a ZMC fracture, which is a fracture complex of this kind of malar region here. And his is depressed inward by several millimeters. And you can clearly see that's why he has that loss of midface projection. So this was an interesting case because it was just kind of one simple displaced segment. I was able to access this just through a small incision on the inside of his upper lip. So it was inside his mouth. And then I was able to get right down on his maxilla and get an elevator under there and basically lift the whole thing up and pop it back into its proper position. Just put one little mini L plate on there to hold it in. And then he would, you can see post-operatively has this nice restoration of his mid-face contour with no external incision. And he healed up beautifully from that. Another example is this other young man who had some blunt trauma to the right cheek after he was playing soccer. And he had like a dent in his cheekbone, so a visible contour deformity. And so this is an isolated zygomatic arch fracture. And these are fractures that sometimes you don't have to put a plate on. You can just do a closed reduction where you just pop it into place and then let it heal. And a tricky part for zygomatic arch fractures is getting the access. And there's several approaches to these zygomatic arch fractures. One is a Gillies approach, which is an external incision, but it's made further up in the hair to kind of camouflage that scar. And so then you have to get in the proper plane, avoiding some of the branches of the facial nerve, and then you can get an elevator under the cheekbone and reduce that depressed fragment back up to restore the contour. I personally like the Keen approach. That's an intraoral incision where you kind of come down from below. Same idea. You get your instrument or your elevator under the cheekbone and pop it back up. And then you can do a more involved approach, which is a coronal approach. So if you have a really comminuted zygomatic arch fracture that actually needs plates, that's the way to do it. Fortunately, in this case, we were able to just do a small intraoral incision. I was able to get under that fracture and pop it up and immediately restored the contour. And sadly, this was another patient I didn't get a chance to meet again, but I'm sure he's doing well because he had a beautiful reduction. Orbital trauma is something that we as ENTs manage all the time, oftentimes in collaboration with our ophthalmology colleagues. But this presents a whole new set of challenges. So orbital floor fractures are very common, unfortunately. These injuries are often called blowout fractures because what you can have is a direct impact to the eye causes this sudden pressure increase. And that drives the thin orbital floor down into the sinus cavity and causes a blowout of the orbit. This can result from, an assault, a punch, sports injuries, falls, motor vehicle accidents. And because of the eye's proximity to this fracture, these patients can develop double vision. They can get a sunken looking eye. They can have restriction in their ability to move their eye and also numbness of the cheek. Unfortunately, not all orbital floor fractures require surgery. The management depends on how big it is and what the patient's associated symptoms are. And we typically kind of get input from ophthalmology early when deciding whether to intervene on these fractures. There are some indications for an emergent repair of an orbital floor fracture. In very rare cases, you can get activation of this oculocardiac reflex, where this pressure results in bradycardia, where the heart rate goes down. And so that's an indication for kind of an emergent repair. And also these muscles that we call the extraocular muscles, the muscles that let you move your eyeball around, they can get stuck in that that fracture line. And so if the patient has evidence that those muscles are entrapped, we want to intervene as soon as possible so we don't get any long-term damage. So for me, I'm pretty conservative about plating orbital floor fractures because a lot of these patients do well without surgery, and it's a high risk area. If you have poor surgical technique or plate placement, you can have issues like muscle entrapment just from the repair. You can have an issue where the lower eyelid is malpositioned. You can have scar bands that form in the eyelid. But in cases where it's really a significant defect, you really do want to consider surgical intervention. And this is one such case. This was another young woman who was also, unfortunately, the victim of an assault. And she had a right orbital floor blowout fracture and also a nasal fracture. And it was, as you can see from these two cross-sectional images, this fracture encompassed a large portion of the orbital floor. And so I was worried she was going to have a long-term issue where it could affect her vision or the eye could sink down in the orbit. And so we did take her to the OR. And generally when we intervene, we repair these by inserting a plate into the orbital floor to hold up the orbital contents. These plates can be made out of titanium, which is my preference. We can also use plates made of other biocompatible synthetic materials like porous polyethylene. And most commonly, the way we access the orbital floor is through a transconjunctival incision. So that's made in the conjunctiva of the lower eyelid. You actually pull the lower eyelid down and make that incision kind of on the inside of the eyelid, and then do a very meticulous dissection down to the orbital floor and lift the contents off of that bony defect and then slide a plate in. The challenging part is to make sure the plate is sitting perfectly after you're finished. And so a lot of us will get imaging postoperatively to confirm that the plate is sitting perfectly. This one is, so I wanted to show this image I was proud of, especially on the sagittal image on the right. You can see that posteriorly, all the way far back, the plate is resting on the posterior ledge and it's not pushed up and it's not missing the ledge. That's exactly what you want to see. And that's probably the trickiest part about plating these, is getting that plate to sit perfectly all the way back. Okay. All right. I'll move on to another aspect of facial trauma, which is nasal trauma. And I see a ton of this in my practice because I also do a lot of nasal surgery. Nasal fractures are the most common type of facial fracture. Everyone knows someone who's broken their nose before. These make up about 50% of all facial fractures. And it's not just fractures of the nasal bones. Nasal trauma can also mean that you have trauma to the cartilage of the nose or soft tissue trauma. Sometimes these are non-operative. So if you have a broken nose, but it's not significantly displaced, you can just leave it alone and it'll heal. But sometimes we do like to reduce these fractures if there's significant displacement of the nasal bones, if there's a corresponding external deformity, like the patient says, look, my nose is now crooked, or if it's significantly comminuted or depressed. Nasal fracture reductions can happen in the operating room or in the clinic, whatever the patient and surgeon preferences. And you're just trying to shift the nasal bones back into their native position. It's not a great option if the trauma is mainly to the cartilage. It's mainly if there's a nasal bone fracture. And of course, it's time sensitive because you got to do it before the bones heal into their new position. This is a woman who I met 2 days after a fall, and immediately she noticed that her nose appeared crooked. And sure enough, on her CT scan, you can see that she has a nasal bone fracture that is displaced somewhat to the left, and that corresponds to what I see on her imaging. She was a good sport. We just took care of it here in the office. I reduced those bones back into their proper position using, in a 10-minute procedure. And then, fortunately, when I saw her afterwards for her follow-up and the cast came off, you can see that she has an excellent realignment of her nasal bones, and we're able to correct that corresponding external deformity. So that's kind of a straightforward nasal fracture. I have another young man who had a much more severe nasal trauma. He was, I think, a professional hockey player, and he was playing hockey and took a hockey puck to the face. And so he presented with just this terrible external deformity where the nasal bones were completely shattered and impacted, and he also couldn't breathe at all through his nose. So this is absolutely something we need to address in the acute period, because this is not something that is going to be easily addressed in a delayed fashion. So he went to the operating room because I just kind of wanted to have the best possible setup. We remolded his nasal bones. Fortunately, they were all very mobile, so we just kind of remolded them back into position. We packed his nose and fashioned this external splint to hold everything together. And he came back to see me 4 months later. I love when my patients come back to see me because we were able to appreciate that he just has this really excellent restoration of his dorsal height. He looks like nothing ever happened to him. He's breathing great. And so this was just really successful success story. He also flew in from Vermont. So he, because he had insurance that would only cover care here in Pennsylvania. So he got on a flight every time to see me. And so I appreciate him coming back. Like I said, nasal trauma can also involve the soft tissue of the nose, and this can be, a real problem. So this is a young man who was an avid mountain biker. And so he had a mountain biking accident where he went over his handlebars and he was wearing sunglasses at the time. And so his sunglasses were pushed down his nasal dorsum and caused a near total avulsive injury of the skin over his nasal dorsum. You can see that soft tissue fragment is hanging on just by one little skin bridge. One of our fantastic residents actually saw him in the emergency room and sewed him up right then and there. And this was immediately post repair. And honestly, I was worried about him because this soft tissue was very purple and congested, and I was worried that it might have its blood supply might have been so disrupted that it wouldn't survive. But when I saw him a week later, it was clearly a viable soft tissue. And then, sure enough, when I saw him again. This is 4 months later. He has a scar, but only if you look hard to see it. And he's still wearing sunglasses, unfortunately, this picture. So, but this was another great success story and great work by one of our residents. I think I just have one more section here. So pan-facial trauma. So you can have multiple facial fractures from these high velocity impacts from ATV accidents, high-speed motor vehicle accidents, falls from a significant height. One example of a panfacial fracture is a Lothrop fracture. Lothrop fractures were named after this French surgeon named René Lothrop, and he studied craniofacial trauma in the early 20th century. And the story goes that he'd actually take cadaver heads and throw them repeatedly at a wall and then dissect them to observe common fracture patterns. And he found that there were these predictable patterns of fractures, and there was 3 common patterns of midface fracture that directly involved the pterygoid plate, and these came to be known as Lothrop 1, 2, and 3 fractures. Since these are high velocity injuries, these patients often have other things going on. They have significant intracranial injury. They might have spinal trauma. So we often see these patients in the ICU and do these repairs on an inpatient basis. I have one more case example of a panfacial trauma. This is not a Lothrop fracture, but I'd still classify it as panfacial. It was an interesting story. It was this really nice 65-year-old gentleman who was out on his deck on a very windy day, and he had one of these large patio umbrellas like you would get from Lowe's, and the wind blew his umbrella over, and that tip of that umbrella struck him in the right cheek, and then it actually went through his sinuses, through the inside of his nose, and then it displaced this huge kind of fracture next to his left eye, essentially into his left orbit. And so he was in really bad shape, and he presented to one of our level 1 trauma centers. Obviously, this is an unfortunate injury, but it was honestly a miracle that that umbrella didn't go, posteriorly into his skull base or intracranially. The other interesting thing about this case was I was reviewing the CT images with one of our residents, and she pointed out this heterogeneous material here in the left maxillary sinus. Truly, I didn't think too much of it. I figured maybe, hematoma or debris. I figured we'd see when we got in there. And sure enough, 2 days later, when we took him to the operating room, we started with a nasal endoscopy, just looking in the nose. And the first thing I saw was this little bit of foreign material peeking out. So we used a sinus instrument to pull it out. And I don't know if you can tell what that is, but it's a big piece of fabric from the umbrella that had somehow gotten sheared off and lodged in his sinuses. So once we removed the foreign bodies, it was still an almost 6-hour operation. We had to expose all these fractures around the orbit and put these plates on. He had a huge orbital floor defect as well, so we had to plate the orbital floor. He had nasal trauma, so we had to reset his nasal bones. We did full sinus surgery for him to clean out his sinuses where they had just been obliterated from the blunt trauma. And then oculoplastics and a strabismus surgeon joined us because there was some damage to his extraocular muscles. And so that had to be repaired directly too by our ophthalmology colleagues. I do have post-surgery imaging for him. And what you can appreciate from these videos is that we have excellent reduction of all these displaced bony fragments. You can see several plates in place, and they're all sitting exactly how we would want them to sit. And he did really well post-operatively and was discharged after, I think, 2 days in the hospital. Okay. All right, so I'm wrapping up soon. I think this is my last slide. Like I said, I really enjoy facial trauma as part of my practice. It's extremely rewarding. We make a huge difference, in the lives of our patients, some of whom have been through some, really traumatizing events. But there are still a lot of logistical challenges associated with managing facial trauma. Increasingly, fewer and fewer providers in the community are managing operative facial trauma. And so these patients often have to be transferred to a tertiary trauma center to get the care they need. And they can really come from, really far away. So not only is that a problem, for their evaluation and getting them scheduled for surgery, especially if we do it on an outpatient basis, but it's also hard for their follow-up, and for them to have, reliable check-ins after their surgery. In addition, this patient population does tend to be, underinsured, which doesn't, stop us from providing care, but it does kind of limit their access. And this can be really frustrating. We have patients who, present to the ED, with acute trauma, and it's operative and they need surgery, but then they're discharged. And then it turns out that even though they were brought to our ED, their insurance doesn't cover for UPMC to do their surgery on an outpatient basis. They have to go find someone else in like Ohio or someone to do it. And that can be really hard to find a surgeon who does this type of surgery for them, especially if they weren't initially evaluated in that ED. So we try to help these patients as much as we can get the care they need, but sometimes we're just limited by the system. Also, these cases, they're time sensitive, they're relatively acute, and so they oftentimes have to happen on an add-on basis. And the OR is really, limited as it is in terms of capacity. And so we're really subject to OR availability, whether they have the staff to accommodate us. And if they do, you never know if something even more acute is going to come in the door, like a brain bleed or something. And so getting these cases in and done is always a logistical challenge. Finally, I've alluded to this several times in this talk, but these patients are often lost to follow-up despite our best efforts. And this has been a focus of a lot of the research efforts of our facial trauma group. The idea here is that we're trying to identify some reliable predictors of patients who are at high risk of being lost to follow-up after we treat their trauma. And interestingly, what we found by looking at our own data is that these patients who have surgery, especially patients who have it on an inpatient basis, so while they're admitted in the hospital, and then patients who are discharged from the hospital without having their follow-up appointment already scheduled, and finally, patients who come from regions with a relatively high area deprivation index. All these are predictors of patients being lost to follow-up after surgery. And so what we're trying to do is use this information to identify these patients in advance and then come up with a strategy to ensure that they have reliable access to care long-term, even after their surgery, so that we can be available if there are complications or concerns or issues. And also for kind of our own learning and research as well. So that's a big focus of our work here at UPMC. And with that, I think I will wrap up. Hopefully that was good in terms of timing. And I thank you all so much for your attention and for indulging me and getting to speak about something that just really I'm passionate about and is a huge part of my practice. So thank you. I'll take any questions.
Oh, well, my goodness. That was just incredible, Dr. Vera. And we do have a few questions in the box, but I probably could talk to you about this all day. There's many questions I have, but it's so complex what you do, and obviously there's a million different skills that you've acquired. But also when I look at this and I think how much different it has to be today than for people, 10 years ago, 20 years ago, for all these complex surgeries. Um, what would you identify as probably the most important advancements in what you do to make the kind of impact that you're making? And by the way, it's impressive. Like when I see like how much you're improving people's lives by
Mhm.
truly bringing them back to, to what they looked like before.
Yeah.
It's just incredible. But what would you say are the most important advancements that led to some of the things that we can do today?
Absolutely. So this field is still rapidly evolving. New advances come out constantly, and I can point to a few kind of trends I've noticed that I've tried to incorporate into my practice. One is like just we're increasingly understanding just the importance of function post-operatively, right? So we can put plates on and reduce fractures, but if the patients aren't functioning well afterwards, their quality of life is never the same. And so one example of this is treatment of mandible fractures, right? Because there's so many issues that can come up afterwards. And that's why I like to see these patients for follow-up. But these patients can have long-term issues with their occlusion and trismus also being a big one, where they forever have trouble kind of opening their mouth all the way. So increasingly, we're focusing on trying to mobilize them and rehabilitate them early. So gone are the days where we leave patients wired shut for like 6 weeks after
Mm.
surgery. If they are wired shut, it's maybe for a week or two, and then we graduate them to elastics to start getting early mobility. And that really helps to minimize the risk of them getting like arthritis in their TMJ joint and having issues with long-term trismus. And so research has been really important to kind of move the field forward in that regard. Technically, there's also like all these advancements that also are applicable to the treatment of head and neck cancer. So I'm sure our head and neck reconstructive group has given webinars on microvascular free tissue
Yeah,
transfer, which is really important
yeah,
for head and neck cancer. But that's used just as frequently in the management of facial trauma. So
I'm
I've had
sure.
patients who had, gunshot wounds to their mandible, and everything was just shattered, and there was just nothing left that I could even plate. And in the old days, maybe what someone would have done is just put a huge plate, like just a bar just spanning that defect, maybe try to do a bone graft or something, but the outcomes were pretty poor. And so these patients are oftentimes candidates for like a fibula free flap, where we use, bone from a whole nother part of the body to reconstruct that defect. In addition, that we work a lot with these various companies like Stryker and Synthes and KLS, that they help provide the plates, but they also have new technology for us to make these surgeries easier. So you can have these plates 3D printed now in advance. So instead of like just taking an hour to bend a plate perfectly while the patient's asleep on the table, you can send them the scans, and they can like reduce the fracture and actually 3D print a plate that should fit perfectly on that fracture, and send it to you before the day of surgery. Obviously, that takes time, and sometimes, if I'm booking someone for surgery the next day, I don't have time to do that, and I know I can bend the plate anyways. But for these really complex fractures, they have so many resources to make what used to be an almost impossible surgery now very doable.
Well, it's just amazing. I've been to the 3D printing
Yep.
facility
Yep.
and
It's
saw
great.
that. It's really incredible.
Yeah.
Well, and I imagine that after watching all the Olympic hockey activity that I can see that you have a lot of athletes that you end up seeing and trauma from sports and is the breakdown more recreational injury or other types of trauma that that you often see? Is it a mixture of that, or is there
Sure.
one group that you see more of?
So it's funny because it's seasonal too. Okay. So
Okay.
so you're exactly right. Sports, out of every sport, it's hockey. It's always hockey, especially
Yeah.
facial trauma from hockey. I have so many young men and women who have seen me after a hockey accident. So be
Mm.
careful, wear your face mask.
Oh yeah.
And that's obviously in the winter. In the winter, we get a lot of mandible fractures from falls, especially elderly patients, because it's icy. So that's another one. In the summer, we get a lot of panfacial trauma, unfortunately, from ATV accidents. So the patterns of trauma that we see vary. Assault tends to be actually a little bit more in the summer because people get a little rowdier. They're at the bar more often. And so
Oh,
I get
wow.
lingual fractures in the summer because that's what you get when you get punched. So yeah, I'd say if we have to say the most common, unfortunately, would be sports and assault and falls. Motor vehicle accidents used to be the number one, but especially in the last few decades, the data has shown that that's gone down somewhat because of safety regulations, seatbelt use, that kind of thing. So yeah, it's interesting.
Well, apparently, walking in the rain is a problem too with umbrellas.
Oh yeah, yeah.
It
Be
was an
careful with umbrellas.
incredible story.
Yeah, some of
Amazing.
these yeah mechanisms of injury are really wild. So
Oh my goodness. Well, I'm sure you have a million stories, but I'll get to the questions that we have. So, in the news lately, we've seen a lot. We've seen more entire face transplants. I'm sorry, due to trauma. Although
mhm.
this is more complex, is this something that we do here in Pittsburgh? And I
I
know
did,
the answer to that.
yeah, that is an exact question that has been posed to me by our residents as well, because everyone hears about that in the news. And there is a lot of progress that has been made in that regard at various centers. I do not believe we've had a full face transplant in Pittsburgh yet, but I anticipate that's something that's going to be coming up just in the next few years. Those type of operations require, like multi-person surgical teams. You have to have the perfect candidate. You have to have a donor. But I do think given how we've seen microvascular reconstruction, kind of become such an important tool in large scale facial trauma management, I do feel like that's going to be the next horizon. And that's something we're probably going to be seeing in Pittsburgh in the next few years.
Thank you.
Yeah.
So, as a facial trauma surgeon, are there activities that you would discourage for adults, but more so for children?
I'm not a fan. I mentioned this. Not a fan of ATVs. So
Oh,
no ATVs for my kids. I don't know if I'm going to let my boys play hockey. I think um, others. I see a lot of like soccer and rugby and that kind of thing. But I think hockey, and then football because I'm worried about the concussion.
yeah.
I don't think my boys will be playing football regardless, even if they wanted to. But those are the two I'd probably discourage. But
Well,
hockey is part of the culture of Pittsburgh, so
you're raising them in Pittsburgh, as
I know, I
you're
know. Tough. It's a tough call. So maybe I'll be.
yes, and they probably are going to they'll probably force your hand at some point if they can.
I know, yeah. So at a certain point, it's not going to be my decision. So we'll see.
But certainly, we appreciate the fact that those two lead to a lot of trauma.
Yeah.
So are there certain like orbital, I think you did answer this actually, but are there orbital surgeries to address trauma where an ophthalmologist also performs procedure in the eye? And you did address one case,
Yeah. Yeah.
so does that happen often or?
Yeah, so we do joint surgery a lot, but these patients who have orbital trauma, oftentimes, it's obviously the ophthalmologist who gets called first, and we really value
Mm,
their evaluation in the emergency room because they're looking for certain things that we can't pick up on our exam, stuff related to the actual eyeball itself. So, for example, if you have like a globe rupture or you have hemorrhage into the anterior chamber of the eye, like a hyphema, these are things that need to be addressed first and managed by ophthalmology. And we really can't proceed with our part of the surgery. I can't go in and do like an orbital floor repair until these things are appropriately managed by ophthalmology. So we collaborate with them very frequently in terms of clinical decision making. Oftentimes, we'll ask them to see and evaluate the patient before we finalize our surgical plan. And then there are also times, like I think I mentioned one or two cases where we actually do surgery together in the operating room. So in that one case, even though I was involved in plating the facial fractures and doing the orbital floor repair, we had an oculoplastic surgeon and a strabismus surgeon join us as well to help plate that medial orbital floor fracture and then also do the repair for the inferior rectus muscle that was affected. So
my
again,
goodness.
even these surgeries can be multi-surgeon efforts. And so we're very used to collaborating, communicating. I have several of the ophthalmology faculty, in my phone, and I will not hesitate to text them if I need their help.
Oh, I imagine. Amazing.
Yeah.
So, when you wire a jaw shut, can a patient get nourishment through a straw, or do they have to have IV or feeding tube?
Ooh, good question. So they can still do PO even when you're wired shut. They can use a straw, but they can also just do a full liquid diet. If you think about it, if you like, I
You don't
tried it
need
myself,
much.
and I know it
Yeah.
can be done. If you clench your teeth together, you can still drink water, you can still drink
Huh.
shakes, but oftentimes they'll unfortunately be on like Ensure or some sort of high protein,
Wow.
for it's a week or two usually. So
Ugh.
they unfortunately may lose a few pounds, but they can do it.
Ugh.
There are cases with really severe trauma where we might consider putting in, an NG tube, a temporary feeding tube. But I don't, if it's just a mandible fracture and it's someone who, is pretty robust, a young male patient, female patient, whoever, I'll just tell them, unfortunately, you're going to be drinking soups and protein shakes for the next 2 weeks.
Oh my goodness. It makes you shiver just thinking how difficult that must be to recover from.
Yeah.
So, when you use bones from elsewhere in the body, which are the most common ones used, and which are the most compatible with jaw bones?
Great. So my disclaimer is that when I have a severe trauma that needs a bone from another part of the body, I'm calling Dr. Spector, Dr. Sherneron, Sarah,
Yeah.
because I don't do free flaps for trauma,
Yes.
at least I do
Yeah.
for other reasons. And so I'll get that team to help me. So we all collaborate on those
Yeah.
cases as well. The fibula bone is the best match for the mandible. And they use fibula free flaps for reconstruction after surgical defects of the mandible for cancer. If you have a
Mhm.
oral cancer that's invading the jawbone, same thing for trauma. If you have a ballistic injury, large segment of the mandible is missing. Generally, it'll be the fibula. I think in other cases, sometimes for large kind of mid-face trauma, sometimes you can use like scapula or that kind of thing. But I don't want to speak out of turn since since I would be calling up one of my colleagues to help with that.
Well, and as I've seen, their presentations as well,
Mhm.
the fibula and the scapula, I'm always amazed that people can actually function quite normally without their fibula and their scapula if need
I
be,
know.
right? So it's
Right,
it's
right. Who knew we had so
um,
many spare parts?
yeah, yeah. Well, when it's removed surgically and strategically, certainly,
Mhm.
but f- unbelievable and fascinating work, and I appreciate how much over the years and decades that things have advanced in this area, and obviously we want to continue to advance that. So, thank you for all that you do. Thank you for thinking of better ways to improve it. Those are things that we try to help you with through the Ioneer Foundation. Those are things that we appreciate help from those who may be hearing this today or sometime down the road. We can advance care, and we can continue to do this, and we can continue to make it better for patients. And that's certainly our goal. And I'm just so overwhelmed with everything you're doing. Thank you so much. Um, thank you, our audience here, and certainly we'll sending these out as a to your inbox with a follow-up, so you can have the recording if you want to send it to friends. This is hard to get information like this at 12 o'clock on a Friday any other way. So thank you very much for attending, and please thank you, Dr. Rivera, for your time here today.
Thank you so much. All right. Appreciate the invitation. Thank you.